So it's health communication in practice, insights and learnings from bicultural skilled workers. So I think that anyone that's been anywhere near public health in the last couple of years knows that, one of the largest lessons that we've learned from this time has been that health messages often don't reach migrant and refugee communities. And also that bicultural workers or multilingual health educators have emerged as key in reaching the communities that are often not reached with the mainstream health communication messages. So today we have Eman al-Dasuqi from the Centre for Culture, Ethnicity and Health, and Shweta Kawatra Dakin from GenWest. And they're going to be kind of sharing their experiences and insights that they've gained from their experience of being bicultural skilled workers. Before I hand over to them, I'll just introduce them. So Eman is a training officer in CEH's Cultural Competence and Health Literacy training team that delivers creative, engaging and practical learning experiences with clients face-to-face, online, in webinars and through e-learning. Eman is also a certified bilingual health educator and a financial literacy peer educator who facilitates in-language culturally appropriate workshops to migrant refugee women. In addition to being a journalism graduate and an audio production and radio enthusiast, Eman has first-hand experience and insights into the Arabic-speaking community's migration experience and their needs. We've also got Shweta, who is a community outreach, engagement and communications professional with vast experience in working with diverse communities. She currently works in health outreach and primary prevention with a focus on improving migrant and refugee women's access to culturally and linguistically appropriate women's health education. A passionate human rights advocate, she is the founding member of 2 refugee-led organisations in Jakarta, and her forte is the ability to navigate cultures, languages and diversity. Shweta has also worked for over 15 years in marketing communications across a range of industries ranging from education to lifestyle and art in Australia, Indonesia, Dubai and India. I'm really looking forward to hearing Shweta and Eman speak for us today, and I'm sure we've got a really engaging presentation coming up. So before you hear too much more from me, I'm going to hand straight over to our presenters. Thank you.
Thank you, Anna.
Thank you, Anna.
Pleasure to be here today. Thank you, HealthWest and Health Literacy Alliance for giving us this platform just to share some gems and insights and learnings from us being on ground, working with groups of women from migrant and refugee backgrounds. And I would also like to say thank you, Shweta, for joining me as well. First, we would like to begin by paying our respects to the Aboriginal people as traditional owners of the land on which we meet today, and to their elders past, present, and recognize the ongoing living culture of all Aboriginal people. I am streaming to you from the land of the Wurundjeri. So the agenda of today's presentation, we're going to talk about the challenges, and there's few of them, and we will talk about how we try to work with them and make them work, and some recommendations, and we will have time for questions and answers. So we wanted to start our presentation with this statement. Unfortunately, we now know that COVID-19 death rates are 3 times higher among migrants when compared with people that were born in Australia. And if anything, this statistic, these numbers, they confirm our concerns and that we have been voicing for the last couple of years. And we have been engaging and working in peer-to-peer education and community engagement, trying to convey some public health messages in a way that they will benefit from it and try to make good health decisions. So the challenges, I'm going to hand it over to you, Shweta. Let's talk about the first chunk, which is communication.
Thanks, Eman. Actually, just looking at the statistics just reminds us of the critical nature of prevention work, because had the prevention work been done, we wouldn't have seen those statistics. Moving on to the challenges, I think a big challenge, which everybody does know about, is communication. But if we break that down, Yes, in-language resources were a challenge where, with such a multicultural population with people from different diverse backgrounds, having communication in language that can be understood by the communities we are speaking to was extremely important. And while the communication over time was developed by the government, whether it was accessible, whether it was language which was really understood by people is another question altogether. So it's not just about creating the resources, also about how adaptable they are and how accessible they are. And the second very important point in terms of communication is, of course, where are we communicating? Is a press conference and a website the place where communities are accessing their information? It's kind of a rhetorical there. So the channels were quite limited and unknown. And to try and actually understand the channels communities were on was a challenge in itself. Finding out where they are and then finding ways to get to accessing those channels and then actually creating information adapted to those channels was an absolute process for all of us. And lastly, of course, was digital literacy and dependence on digital delivery. It was a pandemic. We were in lockdown. We did not have access to people face to face. And then we are speaking to communities who actually do not have digital literacy or access to digital platforms. So how do you get in touch with them and how do you communicate to them? Very, very key challenges. Eman, I will hand over to you on the cultural challenges.
Oh yeah, absolutely. When we're talking about certain health topics, some of them are pretty sensitive and stigmatized, such as mental health, such as sexual and reproductive health. Um, with these sensitive topics, the way that you wanna convey them, and we know now that COVID-19 can affect with these health areas, and it was just very important for us to rephrase the public health messages for them to be heard, because the first point of you're receiving this information, you're like, nope, that does not sound right to me, and that's when people would stop digesting the information. And the principle is for them to make good decisions about their health. So we had to paraphrase and come up with ways that we would make it culturally appropriate. And that does not come like we would receive a basic health information and we would deconstruct it and make it appropriate for our participants to understand. And coming into the systematic issues, we work so hard and there's lots of prep work before delivering a health session. And one of these things that I found myself doing, and it was not a requirement, was fetching local health service providers that have in language, okay, that local health service providers who can speak the language of my participants.
Oh my God, I'm going to turn this right.
Okay. And for example, I was working with the Arabic speaking community. And before I go in to talk about, mental health and how to handle the COVID-19 pandemic and all that sort of anxiety, I would reach out to, is there like a local psychologist who can speak Arabic? Is there like a local GP I can refer them to? Because the ultimate, going back to the principle, I want them to come out of the health session wanting to change and do something. And that I struggle so much with that. There is a shortage of specialists who speak different languages that our communities speak. And even when we are trying to convince people and mission done, people are pumped, they want to go and get vaccinated, they would go out and they would find the system is not ready to service them. Like an example would be, I worked with this family from Iraq, and they're here on a humanitarian visa. And they have their mom is bedbound, but she is not technically disabled. And when we were trying to get her vaccinated at home, she did not meet the criteria. And I was jumping on the phone from one person to another because the big mistake that I said was that they were refugees. And that's when they turned me down. And it was very frustrating. So it's not like people from migrant and refugee background did not want to be vaccinated or don't want to improve their health. It's once we fill them up with all the proper information, evidence-based, culturally appropriate, and they go out, that's when the system sometimes fails them. And this is something that needs to improve. Short-term initiatives. Shweta, would you like to tell us about this one?
That's my favorite bone to pick, to be honest.
Yeah.
Everybody kind of knows that community work is all about establishing trust. It's about being invited into that community. It's about having those relationships, which take time, and developing them takes time, nurturing them takes time, and then maintaining them takes time. But projects that involve health educators in migrant and refugee health education, unfortunately, have been short-term initiatives reacting to an urgent pandemic need. But it has also very clearly highlighted that there is a much deeper issue wherein migrant and refugee communities are not able to actually access health service. As Eman has very clearly said, they might know that they want to get the health service, but they don't have access. And we are trying to build trust here, but our funding is always so short term. It took us 4 months to actually get those ears, to getting those relationships in place. For example, my team, we work with the Kayam Foundation, which is a group of very culturally sensitive and Muslim women from India, Afghanistan, and Pakistan, and we meet them at their religious place of worship. They do not come on video calls. They do not access digital platforms. The only way we can connect with them is through relationship building and having a chin wag about Bollywood superstars and Bollywood songs. That's how you get those relationships going. And then, we get these relationships and say, oh, by the way, sorry, you know what, we're here only for a few months. You're going to trust us. You're going to let us in, but we won't be here the next time you need us. And that really, really hurts our work. So that's one of my biggest and most passionate advocacy point every time. You cannot do community work without a long-term perspective.
Absolutely, especially not in a country like Australia. It's like a migration hub. People will keep coming in. The borders are open. We'll always have new migrants, asylum seekers, refugees, and even the migrants. They are reproducing, and we are having offspring. So there will always be need for health literacy programs embedded into the system, not short-term and responsive. It just doesn't make sense. And in terms of compensation, another thing that we do as bicultural workers is lots of outreach. And when you're doing outreach, you're trying to expand your network. And so much people, they love to say community leaders. No, there are community members that are influential and they are not logged into the registers of the government, okay? So for us to ask them to help us, to lead us for emerging and hidden groups in our communities, this needs time and effort. I'm sure everyone who is attending this presentation today, we get paid to do our work. So why are we asking these people to spend their time and efforts without compensating them? It's very important to have this sort of funding and this chunk of funding always available, because it gives us confidence approaching members of community for more access to those groups. Now, what worked? Okay, I know it's been a bit gloomy so far, but we actually worked with the challenges and we made stuff happen, haven't we, Shweta?
Oh, absolutely.
Let's go. Step one, Shweta.
The people. I mean, it goes without saying, but getting trained, skilled, bicultural people is the most important point. And we're not saying bilingual here. There's a clear distinction between bicultural workers and bilingual workers. And this comes from experience. So for example, while I technically belong to the Indian community and I speak Hindi, English, and Urdu, because of cultural connections and cultural understanding of a South Asian way of being, our entire team has been able to connect with a diaspora of migrants from the Southeast Asian backgrounds. So we are bicultural workers. We have cultural connections with the community, which transcend language. Just being able to understand that language does not give you the access of understanding of the culture. So get a workforce which has a cultural connection. They are trained and skilled. If you look at, one of the projects we keep talking about, we have a project called Women, which is around 50, a workforce of 50 trained, highly skilled health educators. In my team, I have between the four of us, I think 5 master's degrees. And it shows in the kind of work we do, the kind of research that goes in, the kind of thought that goes into the work we do, is because we are highly trained and skilled. And that's the foundation of any bicultural project.
in addition to the skills, we also bring in our lived experience. So most of those bicultural workers, they are at different stages of settlement, and they were resourceful in finding clever ways to go on and find great way to, approach specialists, take care of their health, have children, whatever. So they also bring in some knowledge about the unwritten and cultural social rules and common communication styles and the values and the needs and the aspirations of their communities. Like when armed with paid proper training and combining all of that with their existing skills, you would be in to make practical good outcomes, I would say. So definitely get on with the bicultural workforce. Step 2 would be peer-to-peer education. That's culturally appropriate, evidence-based education. Like this provides like a culturally safe space, and it's not just about speaking the language. Like Shweta said, very important to understand that the type of knowledge in a peer-to-peer module, it's this information that is being exchanged between women from migrant and refugee backgrounds. There's shared lived experience, and it goes much deeper than language. It removes the power imbalance that is common in a medical, like a typical medical appointment. So there are so many gains from this model, and the way we delivered the health message was in a respectful manner. It's non-coercive. Their concerns are valid. Their hesitation is valid, and there were none of the women that I delivered health sessions to were protesting an anti-lockdown or anything like that. And I was not going into an overworked homeschooling, working from home woman with anxiety about when she's going to meet her family overseas and show her a video of a suffocating person on a breathing machine. This is not how you do it. You do it with different messaging, with positive attitude. Let's do this. We can do this together so we can see our families again. It comes from a place of empathy, and you have that from people from within the culture. So peer-to-peer model works, and it's empowering, and the outcomes are amazing. And we don't enable things that are misunderstood, but at the same time, we address it when the time is right. And an example was one of the participants said, I'm a single mom, I have 2 children, I can't bear 2 days laying on the bed because I got vaccinated. And I was like, well, it's only gonna be 2 days of a bit of a sore arm, probably. So that's better than having long COVID and being, in the hospital as the worst outcome from having COVID-19. And this is how you change the perspective in a respectful way. Step 2, where are they communicating, Shweta? Where are they? The cult people, they are so mysterious.
It's not mysterious, Eman, it's just perception, right? Isn't it? It's about, Cal communities are not accessible. Actually, you're just not looking at the places they are at. And the basic rule of communications is be where people are, and find out where they are, tap into the community, get onto the platforms they are at, and communicate from that. As I said before, a press conference might not be the right platform for getting access to those communities. It's a great start, but if you really want the message to go across, figure out where they are. For example, when we were working with the KAM Foundation, we knew that the women have a WhatsApp group. They do not access video calls. They do not come on Zoom, but they communicate by using voice messages. So we pivoted our entire health education outreach with this community by actually recording voice messages in Urdu of whatever we wanted to communicate to them. It was a completely different platform, but it worked. We had access, we gained trust, and in the end, we got the community vaccinated. And now we're continuing these dialogues. We speak to them about topics which they would never, ever allow somebody else to speak to them about, from menopause to mental health to family violence.
Yep.
All because we tapped the platform they are actually at, and it's a safe space for them, and we got invited into that space.
Yep. And it was some sort of the same experience with me. There was a group of women from a Saudi background, and they do not feel comfortable, declaring their names, having it on the registers, and they use anonymous names online, and they love Instagram. So I talked to the coordinator of the group, and I was like, I'm happy to go live on Insta. I mean, I don't care as long as I have the message across. And we did. And I delivered, and they engaged, and it was fantastic. And we heard great stuff afterwards. So we find them where they are. And this is like a screenshot of an article on SBS that was an interview. When we say bicultural workers bring in their skills, from my journalistic background, I had some, connections with a journalist in SBS. And she was like, Eman, could you please do an interview and talk about the project you're working in? And I did. And we received requests and people were interacting. So step 4 in terms of health information, like we said, when we're talking about translated material, we do a little bit more than that. We would culturally translate it in plain language and dissect it and deconstruct it. And we would tailor it to the needs of each group. The same health message I would not deliver the same way to a senior group or a group of moms or a group with women with disability. What do you reckon about the culturally appropriate, Shweta?
It is such a process, isn't it? I remember walking into a conversation with a group of Indian women, and God forbid we talk about mental health, and God forbid we use the word postnatal depression or depression. Having said that, I'm Indian, I'm a migrant, I'm one of them, and I opened the Pandora's box and said, hey, by the way, I've had PTSD, I've had postnatal depression, I've been on meds, and it worked for me. That's that example for me brought together everything I have learned in the last 7 months. If you belong to the community, you're trained, you address it in a culturally appropriate manner, you talk in a language they understand, not the literal translation of a health message, but you actually package it in a language which is accessible and sensitive and talks about your own lived experience, the response you get is so much more positive and encouraging.
Agreed. And when we're saying technically compatible, we found ourselves converting so many files into things that will work on WhatsApp and on Instagram. So I'm not going to share like a whole PDF on WhatsApp. No one's going to read it using a third-party application. So that's another thing. Consistency. So you don't put us in an embarrassing spot where one part health specialist saying something as a public message and then the government saying something else, and that decrease our integrity as professionals going into the community. So another way to increase communication is supporting your bicultural workers, and that's by entrusting our knowledge and skills. Have faith in us, we know what we are doing, and recognize the mutually beneficial relationship. So we are like a medium between the organization and the community, and we will keep the communication going back and forth. It is a two-way communication. I reckon we can send these resources later to everyone here. These are great resources that will improve your work and help you. And thank you for listening to us. It's been a pleasure. And now we are happy to receive your questions. And I'm going to stop sharing my screen.
Yes, we have a very interesting question there, actually, which I'd like to take up. JB, thanks for the question. And the question is about project comms deliverables that are not there in funding bodies right now, which could help with the barriers. For example, Eman, what you mentioned, a budget for community leaders. When we access community leaders, normally it is understood that they will do it because of the goodness of their heart and because they love their community, which is all well and good. But I think it's very important when we're looking at projects, when we're looking at planning for projects and looking for funding, to definitely have resource allocations for compensation of people in the community. I have never seen that in a budget or a project plan. Even things like compensating the people who come to our health education sessions, that has come up so often when we're out in the community. And because there's so many barriers to these migrant and refugee women to access the sessions, sometimes it's important to also give them incentives to be there, which I feel has not been a part of our budget. So there are those kind of financial barriers, which would be really good to see in project planning from a budgeting perspective.
Yep. And I'm reading a note here. Join communities where they are present in their social forums with permission. I love how you said with permission. You know, I am from the Arabic speaking community, and there are certain groups I need to ask for permission to be let in. We can't just because we speak the same language, poof, open the door. Hi, I'm here to tell you all about your health and preach. No, it doesn't work like that. So very important. Thank you.
There's one question which is asking whether either of us are involved in the disability space. So we have worked in the disability space with other organizations like ADEC. Having said that, the prime focus is migrant and refugee backgrounds, but I feel that because we have the Culturally Connect, we can at least address some of the barriers that they face. And there is a kind of an intersectionality between barriers faced by migrant and refugee women and barriers faced by the disability sector, but we don't specifically address that per se. The first focus is migrant and refugees, and if there is a intersectionality of disability, we do try and speak to them, but we don't focus on them.
And Marianne, is there a directory or even list of bicultural workers? We have 200 languages in our region, and not sure there's bicultural workers for all languages we try and work with. Co-Health just recently started a bilingual bicultural workers network, which is a great initiative, long awaited, about time. So I would be happy to refer you to Jasmine Phillips, I think, she's taking care and coordinating that from Co-Health. Yep.
And the MCWH has a program which basically is bicultural health educators. They have a team, extremely, if I may say so, sorry, MCWH, extremely underfunded. One of the biggest projects which Eman and I worked on, and we still work for, Multicultural Center for Women's Health, sorry about that, was the Women's Project, which was a 6-month project started in May to provide employment to migrant and refugee women and follow a peer-to-peer health education way of educating migrant and refugee populations. The project was so successful, and we made such amazing we had such amazing results that it got funded again for 6 months. Having said that, hashtag sick of short-term funding.
Yeah, sick of small changes as well.
Yeah.
We deserve better than that. Victorian women deserve better than that, and they need to be sustainable. We're talking about a human right here, health, and it has been, there has always been issues, but it has been magnified by the pandemic, and the time to act is now and here.
So to wrap up, we just say peer-to-peer health education using a bicultural trained workforce is the solution.
Yep.
Bottom line.
So Marianne is saying funding is problematic. We are dependent on government funding, which too often is last minute and short term. Yeah, it's very important to address this point, Marianne. It's like we said, it takes time for us to build this trust with the communities and for it to be shortcut. And it is hard for me because we approach our roles with integrity. There's lots of empathy that drives us on how we work. And for a group of women who feel like, yes, we are happy to talk, to learn more about our health, we're happy to book, and you say, the project turns out I'm not going to get paid anymore. I will not have the resources. So we need to do better than this.
Okay, there's one question coming in. Sorry, Sharika, any advice on making a case for recommendations in a mostly white organization? Be the change.
Exactly.
We need a seat on the table, but unfortunately for us to get a seat on the table, somebody needs to give up their seat.
Yeah.
That's
So
what I say.
inclusion and diversity, you can't have diversity without inclusion. And we as representatives of our communities or as people who are like us, we would like a seat on the table, on the decision-making table. We would like to be consulted in every stage of designing these projects and programs because we have been on the ground, we have our lived experience, so we have our 2 cents that we would like to contribute, and we would like to be compensated for our time, just like everybody else. And opening pathways for bicultural workers to keep moving forward and climb up the ladder on the chain of order, chain of command. We would like that too. But meanwhile, our allies are helping us. We will be doing our job with the best way that we can.
We take one more question before we wrap up. Anybody, or we'll just sign off by saying, give us a seat on the table. Let's co-design projects and follow a peer-to-peer bicultural health education model. That's it.
Thank you so much for attending. Thank you. Thank you. We appreciate it.
Thank you, everyone. Thanks for inviting us.
Amazing. Thank you so much, Eman and Shweta, for your presentations. I can't add anything more that would add anything to your presentation. So I'll leave it with your words, other than that there's a call of action for every one of us in there to make big changes and do things very differently to get the results that we're all looking for.
I'll just pop my email in the chat because there was a question there about how do we contact, and please email us. We are more than happy to answer any questions and even come and do health education sessions for your cohorts or communities you work with. We've been funded till end of May, so.
Yep.
Not long. Like we said, the recording, the session's been recorded, so we'll send that around, and we'll also be able to send contact details for anyone to follow up with any specific questions. Really hope to see a lot more from bicultural skilled workers into the future as the main way of working on health communications to come.
Thank you.
And I highly recommend for people looking to improve their cultural competence, to improve the way they are working with interpreters, to improve their health literacy. CEH has amazing training modules and e-learning. Highly recommend it. Not only because I'm a training officer there, but from my assessment, from the eyes of a migrant woman, I approve, and it's been working, and I learned myself a lot. So there's always a capacity to learn and to improve the way that we are working and to make our workplaces, a growing ground for all this great potential that we can see in our society. So yeah, ceh.org.au.
Good plug-in, Eman.
Smooth, isn't it?
It's your privilege.
Thank you, everyone. Thanks for the platform. And please email us with anything you might need.
Yep.
Great.
Bye-bye.
Thank you both very much. And thank you to everyone that's joined us for the session today.